Gaetano, do you remember what Dr. K asked us to research for perio?
I came here knowing nothing. I'd like to keep it that way. Oh yeah, what is the evidence to support the need for correcting mucogingival deformities prior to restorative therapy?
So what did you find out?
There are 4 main reasons why periodontal disease should be eliminated before any restorative dentistry is started in the patient's mouth. 1. Gingival shrinkage can occur after periodontal treatment, which can alter the aesthetics of restorations placed. 2. After inflammation is eliminated, the position of teeth may be changed, which can alter contact points and occlusion. 3. Inflamed periodontium can weaken abutment teeth, as if it is diseased. 4. It would be difficult to obtain accurate impression on inflamed tissue, as they are not completely stable and can change over time.
I'm impressed. I read an article that focused on the relevance of maintaining biologic width in order to promote periodontal health before definitive restorations are placed. It gave an overview of biologic width and how you need to maintain a minimum of 2 mm of attached gingiva between the alveolar bone and the margin of the restoration so that the gingiva has a healthy, protective space to attach to the tooth surface.
I know that to avoid violating the biological width, the restorative dentist should measure probing depths before preparing the teeth, and margins should not be placed more than 0.5 mm into a healthy gingival sulcus. Crown lengthening is a valuable adjunctive procedure in restorative dentistry and is indicated for encroaching the biological width from restorations, caries, or fractures. Encroaching the biological width can lead to bacterial accumulation, further leading to inflammation and gingival recession. It is suggested that final tooth preparation and restoration be delayed until after healing from crown lengthening has occurred, which is typically 90 days. The restorative alveolar interface technique was described as the portion of the root surface extending from the alveolar crest apically to the restorative margin coronally. To allow for more effective plaque control, it consists of modifying the restorative margin position into a healthier environment, to better respect the biological width. This study defines 4 clinical cases with the indication for this technique for maintenance of a healthy periodontium. These 4 cases were all associated with prosthetic dental procedures. All 4 cases were evaluated at a 90-day mark, and all displayed a healthy periodontal tissue.
I already knew that, but that was swell of you to tell me anyway.
Gosh, you really know your perio.
A systematic review showed the efficacy of various methods for obtaining keratinized mucosa at implant sites. The techniques studied were based on an apically positioned flap, vestibuloplasty, in addition to some graft material. The most successful graft materials to increase keratinized mucosa width were free gingival grafts and subepithelial connective tissue grafts. Collagen matrix grafting showed less success but resulted in less patient morbidity and surgery time compared to the other 2 graft materials. Also, soft tissue substitutes were shown to have insufficient clinical data to be recommended.
Girl, did you know that the data that is currently available from previous research suggests that if a patient follows a consistent and effective oral hygiene regimen, the soft tissue surrounding an implant can be maintained even without a thick band of keratinized gingival tissue? The problem tends to involve the difficulty of maintaining good oral hygiene without this band of keratinized tissue.
Let's get married this weekend. I want to marry a real man, a periodontist who knows his research.
Well, that was an interesting dream you had last night indeed. Maybe Santa will make it come true for you this year. Oh, don't worry, Dad, I know he will. I've been good all year and have been doing tons of perio on clinic. I'll get her for sure. Yeah, if you say so.